Go ahead and
Okay.
Lloyd.
Well, we've really, first of all, thanks to both David and Lloyd for covering this topic. Medicare Advantage has sort of come out of, I won't say nowhere over the past few years, but it's climbing, and it's now a majority of Medicare recipients are now Medicare Advantage clients, patients, enrollees, whatever you want to call it. And we asked David to talk a bit about the background of that, particularly given David's background in the early days of managed care and kind of being a counsel to Medicare Advantage Plans Alliance, the various things he's had involvement with. And then Lloyd Brodsky, whom you all virtually all remember from his years here being with us. Lloyd, in his next life, has actually become a Medicare Advantage consultant, helping people looking for plans find them. And Lloyd and I had a couple of fascinating conversations about the reality of that landscape. And we've asked Lloyd to give us a bit of information about that, which I think will be really interesting. And to the degree there's time, I'll fill in a little bit. I've just, as many of you know, I just lost my wife about a month ago, and I had some experiences with our Medicare Advantage situation during all of that. So I've got a few thoughts about that, but I don't want to taint this discussion too much with that. So anyway, David, why don't you kick us off, and we'll
I'll
go
try
from there.
to hit some high points here. The real question that a lot of people have is, what is a Medicare Advantage plan, and where did it come from? And you know, a longstanding debate in healthcare has been, should healthcare be run like government clinics, more like what the British system is, or should it be more private sector oriented, or some combination of those two? Going back to the early days of HMOs is really where we have to start. And I'll tell a side story that I haven't heard anywhere else, but someone told me a number of years ago about where the term health maintenance organization came from. Turns out you have to go back to the Nixon administration. And during the Nixon administration, if I'm not mistaken, the secretary of HEW back at the time was Elliot Richardson, speaking of Saturday Night Massacres. And he ended up being in that position. And a group of people from the Midwest, run by, that was sort of moderated by a guy named Paul Elwood, a name out of the past you may or may not remember, got a group of people together, and they had learned about the concept of HMOs from looking at Kaiser and an organization called HIP Health Plans out of New Jersey. Now, during those days, there was a lot of concern about healthcare inflation. You might even remember that Jimmy Carter and Joe Califano, the secretary later on, put together a bill that would limit hospital revenues to a 9% increase each year. And it was a bill about this thick, and it was really complicated, and it came before the Congress, but healthcare inflation, especially hospital inflation, was well over 10%. This would have put a 9% cap on it, but it was up around 12%. So people were really concerned about that. And this whole idea of HMOs struck people as a way to address that problem, as well as the problem of lack of access. So essentially, they came to Washington and they flew in. They were going to have the meeting the next day. They were having dinner, and they were calling these organizations, and this concept that they had in mind, health management organizations. But they were going to the Nixon administration, and they decided that it wasn't going to sound very good. So they had all their papers developed, that they were their handouts and that kind of thing. And they said, we got to come up with a better name. So they came up with, how about maintenance? We're going to maintain health rather than manage health, because manage sounded too much like Ted Kennedy and that whole Democratic thing. And you're going to the Republicans. So they decided to change that. And speaking of technology and days before computers even, what they had to do was figure out a way to change their papers so that they didn't say management anymore. It said maintenance. So they had to, they came up with maintenance because it had the same number of letters in it as management. And so remember those strips of white
Right.
that you used to be able to correct your typos with?
No.
They had some of that. And so somehow I guess they must have done it on a typewriter, but they went through their papers and they changed management to maintenance. And that changed the whole concept. turns out the Nixon administration kind of liked the idea, and eventually it led to the HMO Act of 1973, which put together a program of grants and loans to help people, private sector people, start up health maintenance organizations. And I'll skip over, there were several different types, but the whole idea was to put together a private sector amalgamation of providers and insurance people who would have these organizations that would help people enroll and maintain health. Okay, well, those actually caught on pretty well over the next several years. I was actually fortunate enough to work on a set of amendments in 1978 that modified some of the requirements to make them a little friendlier to the private sector. And the senator I worked for, who many of you ended up knowing because he came here for many years, was Dick Schweiker. He was the ranking Republican with Ted Kennedy, and Kennedy asked Dick to put this bill together. And I was one of the most, everybody else was worried about more important legislation like national health insurance, health planning, peer reviews, PSROs, all that kind of thing. So as one of the more junior staffers, they assigned this to me, and I ended up drafting these amendments and ended up going to a law firm that went around the country starting up HMOs for a number of years. So flash forward a few years past 1978, there was another senator from Pennsylvania whose name was Hines, John Hines, if you might remember him. And he had the idea to apply HMOs to Medicare. In other words, give Medicare beneficiaries the option to join an HMO and give the HMOs the option of running Medicare. So this was a public-private sector partnership that was essentially put together. And the theory was that HMOs would save money. And basically the industry said, we know we can save at least 5% of what is being spent now on traditional Medicare, because we know we can manage the care and we can negotiate prices and all that sort of thing. So how do you calculate that? Well, they came up with this concept called the AAPCC, the average adjusted per capita cost. And the government tried to figure out what depending upon the age and the health status of different beneficiaries, what the AAPCC would be for certain beneficiaries. And they would pay the HMO 95% of that amount.
So the ultimate actuarial problem.
Yes. Well, it became a big problem because going forward, it started out pretty well, but eventually the government started using old data. So the calculations were off. They just were totally off. And a lot of the plans that started off in the, in this new industry dropped out, and the whole thing was going downhill. So eventually they started paying them more later on, but that eventually led to Pete Stark. Remember him from Capitol Hill? He was head of the Health Subcommittee, I guess it was, of the Ways and Means Committee. And he was basically saying the Medicare Advantage plans were ripping off the federal government. They were paying too much. And it's true, they were paying more than 100%, although they gave a lot of extra benefits to beneficiaries, and the beneficiaries seemed to like it. But Stark picked up this cause, and part of the problem was that a number of Medicare Advantage plans were not HMOs, they were PPOs, and the beneficiaries could go off to almost any provider, and the plan would have to pay that, and then they would do their calculations. And Stark essentially said, we got to close this program down. This was back in the 80s. No, I'm sorry. It was back in about 2010, I think, that this whole thing erupted. So some of the plans, one of which I represented, started trying to come up with ideas. And eventually they came up with a star rating system for HMO, for Medicare Advantage plans. And depending upon the satisfaction of beneficiaries and the cost containment of operations and a number of other factors, a plan would either get a 5-star rating or 4-star, 4-star to 3-star. And if you got a lower rating, you being the plan got a lower rating, you didn't get paid as much. Or if it got really bad, CMS could actually write a letter to all of your beneficiaries and say, you can leave if you want to. And so, but essentially the plans that were good ended up getting paid very well. And they, in many cases, were giving out fairly good care. And so essentially, though, the argument has always come up, are these beneficiaries getting the extra benefits that they're told they're getting when they sign up? Because essentially, it depends on where you are, and Lloyd will speak to this in a little more detail, perhaps. In Washington, D.C., there are scores and scores of options in the private sector, and you've heard about them on cable TV, in November, all the different options. If you go out west or in rural areas, there might only be 2 or 3, but it's very hard for a senior citizen to figure this out. And that's why there's a broker industry out there that is also available. And I actually used a broker to find a Medicare Advantage plan of my own. But essentially, the trick is for the plans to come up with a good plan on which they can make some money, but not too much. Is kind of how it's going these days. Now, Ron Wyden, the senator from Oregon, about 6 months ago, came out with a bunch of critiques of Medicare Advantage plans. And there were a number of them, but he put out a paper that basically said the beneficiaries are confused. They don't know what services they're getting. Sometimes they get denials of coverage because they don't have prior authorization, and they're older people and they don't know how to fight for themselves, and things can really get confusing, and that has to be fixed. So a lot of confusion about benefit structures and designs because they're not standardized. They're different depending on the plan that you select. And sometimes too, the plans drop out. So I was in an Aetna plan, and I found out in November that they were canceling the plan I was in. So I had to go back to the broker and find another one, which operated slightly differently. And I had to figure out what drugs I needed to have covered and that kind of thing. But the other problem that Wyden pointed out is that there's what they call a risk adjustment done every year, because plans, if they are treating patients that are sicker than others or older, and they're actuarially speaking, they are not making as much money as they should because they're giving out more care, there's this process called risk adjustment. And there are plenty of accusations, and a number of them are aimed at United, Allison, not surprisingly, that the plans are not properly sending in the right data, and they're getting too much money as a result of the risk adjustment process, which they are saying is borderline fraudulent, this risk adjustment process, and that has to be fixed. So those are some of the criticisms of Medicare Advantage plans. Having said that, as Jim pointed out, well, more than half, maybe 56% or so of Medicare beneficiaries have chosen these plans over traditional Medicare. And part of the reason is you don't have to get a Medicare supplement plan. The way you do if you're in traditional Medicare, which can cost $400 or $500 a month per person. But you also get a number of extra benefits. In my case, I'm getting, I'm getting up to $3,500 a year in dental insurance, dental costs. You can get free transportation to medical appointments, vision care, hearing aids, things like this get thrown in. And so in many cases, beneficiaries really like that. So I'll finish up by just trying to point out what's going on with the Medicare Advantage plans now and the challenges that they're facing. Right now, they're kind of, in their view, if you talk to the compliance officers and the CEOs of these plans, they're getting audited all the time. A single Medicare Advantage plan may have 2 or 3 audits going on at once. And the people who have to be in those audits are often people who are supposed to be running the health plan. And the audits go on for a week or 2, maybe sometimes longer. And the odd thing is, and we're going to take this to Mehmet Oz when he gets sworn in or somebody like that, the results of the audits are not compiled and made known to the plans for up to 2 years. Up to 2 years. Now,
CMS audits, I'm guessing?
These are CMS
Okay.
outside contractor audits.
Okay.
Yeah, I can't remember the name of the contractors, but and many of the contractors don't really understand managed care. They don't understand the industry. So the plans have to educate them about what's going on. And then they come up with problems that they see. Some of them might be totally legitimate, but the plans don't find out about it. And there are so many of these audits going on that they feel are too expensive. And in many cases, that's why plans are starting to drop out again, because they just don't feel like they're making any money, and the whole thing is overregulated. So we'll see how this goes. I personally feel that I shouldn't say that essentially because I'm not sure it is actually true. But I know there are a number of Medicare Advantage plans that feel that they have an incentive to give out good care and to retain their beneficiaries, at least through, a certain age group or a certain set of circumstances. There are some of the large plans that probably, like United, that may be having serious difficulties in terms of processing of claims and serving their beneficiaries. But it seems to me that the plans have an incentive not to do that sort of thing because it can be very expensive to have to deal with accusations of fraud and abuse and inappropriate administration of these plans. So we'll see what the new administration says.
Question, in the managed care plans, are there claims denials? I mean, these are they're getting paid for encounters. Is there a scenario where they're denying claims in the managed care environment? Or I guess the care.
Well, they do deny some claims in the Medicare Advantage world. A lot of times patients get frustrated because it's not clear when they need prior authorization. And the patient will go to a particular doctor. I've had a couple of situations, even with my background in this whole area, where I've been told that a particular provider is a participating provider, and it turns out they're not. So when I was with Aetna, I went to a dermatologist. Dermatologist said, "Oh yeah, we take Aetna," but they didn't take the particular plan I was in. They weren't participating in that one, and the people working at the front desk didn't know the difference. I actually, when I changed plans, moved my appointment to after the anniversary date so I could be covered. I went for the appointment, and before I actually went in, it turned out that I checked with the plan, and they said, "No, we're not participating in that plan." And so I had to change dermatologists, and that wasn't a very expensive experience. But if it had been hospitalization or something having to do with a physician visit, that can really get confusing. So I have to sometimes help them do their own legal work.
I mean, if you multiply that experience times millions,
It's a lot.
I mean, it creates a lot of more, you're saying more expensive because of people not knowing.
Yeah,
Especially on the rural health community.
that's true. And of course, again, you're dealing with an aging population.
Yeah.
So they maybe they have more time to sit on hold, but other than that, it's pretty frustrating.
David, how does Kaiser fare in all this compared? Because Kaiser has everybody under, they have the hospitals, and they have the doctors, the insurance, all under one roof. And Halverston, the founder of Kaiser, said he felt that vertically integrated model was really the way to deliver care, because then you don't have the friction between, the insurers and the physicians and the hospitals. Of course, that all sounds great on the outside. I've heard it's not fairy tale land on the inside. It's easy.
Kaiser, I think, has a pretty good reputation in terms of its integrated care, its electronic medical records, and the way they give out care. But I mean, some people feel, I've heard some people say that the Kaiser care can be kind of standardized rather than.
Yeah, it's great. I worked for Kaiser for 5 years.
Oh, well,
it's great in
East or West?
healthcare.
Kaiser West.
It's great. What?
It's great. It works great until you need healthcare.
Well, it's not as good as specialized.
The West Coast is very different.
Yeah.
Yeah, for what it's worth, some of my wife was an emergency room nurse for many years, and she would not go within 100 miles of a Kaiser plan because she said their emergency room routinely got the Kaiser rejects, difficulties, mostly dealing with specialty care, where somebody, and it's not that they gave bad care, it's that you could frequently get months-long delays in seeing the particular specialist you needed, and the patients would get frustrated and go to the emergency room.
Well, interestingly, Kaiser seems to do better in California because that's obviously where it started. They tried to come out here on the East Coast, and I don't think it's gone very well for them.
They don't own the hospitals, right?
Yeah,
They have arrangements with their own.
because it's harder for them to consolidate everything the way in here, the way they do in California.
Like the interesting thing, like I'm from California, my brothers are out there. Actually, one is, the other one moved to Vegas not too long ago. But for the one out there, like, when there was a family member, unfortunately, in a pretty serious medical condition, particular cancer. So it's not like there was a Kaiser hospital or Kaiser physician group with that oncology specialist, 10 miles from them, in Valencia, and way in there's LA. If they wanted to see a general, just a regular plain old vanilla oncologist, yeah, they could see one a few miles away. But if they wanted that particular, maybe it was a breast, let's say, just for sake of argument, it was a breast cancer expert, then they had to go to Kaiser downtown Los Angeles and basically stay in a motel or hotel overnight, because that's where that was the closest one in that specialty.
Yeah.
So, because they're trying to optimize resources. But on the other hand, like for hospice care, apparently they were great. I mean, they sent them to the house, and you were just wondering, it all worked.
So I'm
Of
a
course,
Kaiser
one of the-
patient. I'm a Kaiser patient.
Are you?
Yeah. And it's probably the best care I've ever gotten.
Really?
Yeah. And I'm a
Okay.
physician.
Okay.
But everything is on my electronic, everything's on my phone, right? My dates, my times, appointments, patient, right here. And it's really been easy to access care. Now I live right down the street from a Kaiser facility. I live right here on Capitol Hill. So maybe my view is jaded as compared to somebody who has to travel a significant amount of time. But this is great care. Sorry.
Well, I think access to specialists in particular is a big issue for people who are thinking about Medicare Advantage. I don't have that many health problems that I can't handle with a few doctors. My wife, on the other hand, has had a number of more serious problems, and she wouldn't do well in Medicare Advantage because she has particular doctors that she wants to see who know her history and that kind of thing. So she stayed with traditional Medicare. But you can do HMOs or you can do PPOs, and a Medicare Advantage PPO plan is not a bad deal because you can go outside the network.
Right.
You just have to pay a little bit higher copay, and you can make that choice.
But if you're in a Medicare Advantage PPO and you're in network, do you still need prior authorization?
Much less.
It depends on the plan.
Depends on the plan.
Because
It depends on the
PPO
service.
usually means if they're in the plan, you can just go.
Yeah.
At least that's
Why don't we move on? And Lloyd is now I'm sure we could talk about this for the next month, but
Yeah.
Lloyd can muddy this waters even more, I suppose. But as I said earlier, Lloyd's been working as an insurance broker and has a lot of information about how
The
these
receptionist.
plans actually work and how things work out for patients. So Lloyd, let me turn it over to you.
Okay, thanks. But before I start my talk, let me just tell you a bit about what I was and am now up to. I spent about 15 years at Optum Insight, which is part of United Health, and CSC, doing data warehouses, doing claims data warehouses and analytics for government insurance clients, sometimes the VA, sometimes military health. But for the past 10 years, it was mostly Medicaid for state governments. So I spent a lot of time doing pop health statistics. After I left Optum and retired and moved down here, it had dawned on me that I had managed to spend more than 10 years supporting Medicaid programs without ever having met anybody on Medicaid, which felt wrong somehow. And in trying to find something socially useful to do before I passed away, I started volunteering at a large food bank in Gwinnett County, where it turned out, somewhat to my surprise, that there were an awful lot of people who hadn't signed up for government health insurance benefits that they were entitled to. I mean, the seniors had signed up for Medicare, but if you're low income, there's this thing called the Medicare Savings Program.